Hello everybody, my name is John Prickett and I'm presenting my scholarly DNP project today, and the title is Jail Hypertension Project. This is for Nursing 707 and Professor Dr. Maria Snell. In my committee slide, my DNP chair is Dr. Ashton Lindsay, and my community member of choice was the jail commander James McFarland. So background significance. The aim and the purpose of the scholarly project was to review and update current hypertension management guidelines that were at a jail. And so by doing so, I used the American College of Cardiology and the American Heart Association, but stylized by Up to Date, which made it very user-friendly and visually appealing for the jail staff to actually use. And this is for male inmates between the ages of 18 through 89. So background is rates of hypertension are certainly exceedingly high within jail populations, especially amongst males. The risk of cardiac adverse events, especially related to poor hypertension management, for the majority of patients are very preventable, and often these are overlooked within the jail setting. So this can lead to unneeded hospitalizations and chronic illnesses and premature death. This increases the cost of care and places a burden on communities alike, especially when released from prison. This can lead to poor patient and staff satisfaction and lower quality of life. Screening for and managing hypertension then is of the utmost importance, especially significantly within this population, to improve patients' quality of life and to decrease higher healthcare costs. So the review of the literature to find out was this a reasonable approach to take there are certainly many articles, but there was quite a few excluded. Of those reviewed top 40 or 50, 23 of the articles really were found to be supportive of that, outside of the evidence used and reviewed for guidelines that are currently established today for hypertension management. The jail of question was essentially using an outdated hypertension management tool. So 23 articles were grouped into the following three themes. So we had hypertension risk factors, management, and prevalence. So how do we take care of it, who's at risk, and how common is it? So these themes provided the most evidence and guidance to support this scholarly DNP project. The objective, again, was to find support to substantiate the need for updating these hypertension management guidelines for jail medical workers and incarcerated males with hypertension. Rates of hypertension are highest among men compared to women, especially below 60 years of age. Prison and jail settings are where some of the highest at-risk populations coincide. Majority of the inmates are male, making screening that much more critical. So not only does this phenomenon exist, but then you also have lack of dietary options and exercise, which just increases the risk factor of many other components with heart disease outside of hypertension. Education level, perception of value, it is of the lowest within jail settings, so making resistance to management care plans harder for jail medical workers. And to add complications to this demographic, you have a high amount of drug use. You've got methamphetamine, tobacco, alcohol abuse, which are the highest among this group in the nation. It's a perfect storm. So this group was a perfect population to focus on. In fact, it's a vulnerable population. Often has different management strategies before and after incarceration. It leads to many poor outcomes. So this group needs help. Nationally, the literature supports that. So how do we put something together to make this work? So I liked Lippitt's model of change, and specifically this was created by 3 different theorists, and it focuses on a 7-step model. Now, as you can see here below, it needs to develop a need for change by diagnosing the change. Well, we already know that hypertension management is not well established. So how do we do that? Well, we establish a change relationship, and we assess the motivation and capacity to change. As we already know, just working in our day-to-day lives and as employees for large healthcare systems, any change can come with a certain amount of time that it takes to establish that change and then make those changes stay and stick, make a new habit. So I really like this, especially for setting up the framework for the medical staff to be successful, but also kind of understand the why. So they had to clarify that assessment for change and determine resources, establish goals and intentions for an action plan, and also examine alternatives. What other options could we have? Is this really the best decision? But we have to transform those intentions into actual change and maintain the change. So generalize and stabilize change and end the helping relationship near the end, so then the workers can continue that change model on their own. So this was a very useful aspect for this DNP project, as introducing change to medical staff with updated hypertension algorithms needs further structure than goals themselves. It needs to be interesting. It also needs to be of value. Why would we do something? We have to explain the why, right? So this was applied to male inmates at this local jail, saying, hey, this required substantive changes. The rates of hypertension are fairly high here, but they're not being as controlled as they should be. Should we look into other aspects? So Lippitt's model of change was very useful, and it introduced and changed the motivation of medical staff while establishing goals and stabilizing those changes. Again, stabilizing those changes so they don't go anywhere, right? We want to continue this new habit. So the projected time for this project was set at 12 weeks just to ensure habits, and it's been proven that it takes a minimum of 6 weeks for any new habit to actually stay formed, and that's actually true of many things. So I felt like if we doubled it, we'd have better success to slowly introduce this, especially since I'm not a full staff member here at this jail. I was a guest. So methods and design. So how did we, what methods, what designs did we use to create this project? Well, a quantitative exploratory design through a retrospective chart review was utilized for this project, which was best because no actual contact was being made place. Participants were not engaged, and no patient information was abstracted from the electronic medical records. Electronic and some paper medical records, majority electronic, were utilized from the jail for data collection. And so it was really a partnership between the jail medical staff and myself and the goals of a larger outcome of controlled hypertension that made this project successful. The researcher, myself, recorded the minimum amount of data necessary to accomplish the goals for the project on a data collection sheet, and then of course all potential patient identifiers were removed, and they were not collected for this aspect, mainly because we were just interested in the numbers. The guideline algorithm. So what is it that we're trying to establish? What are we trying to use? Well, screening and diagnosis for hypertension. We want to determine the risk for hypertension. Look at lifestyle modifications. Jail cells are known for having poor dietary choices and high salt in their food options. So how could we adjust those lifestyle modifications? Would it be cheaper, more expensive? Category of hypertension. Of course, certain different risks. We're looking at a group between 18 to 89. That is a wide array of hypertension risks. The way we would treat someone at a younger age versus early or later age is very different. And looking at different pharmacological choices depending on race, gender, different disease processes that they've had, such as diabetes, that changes our pharmacologic choices. And then, of course, review of management. That is really where this project came in. We're using guidelines that have been established nationally, that have been proven to work. So out of this jail, now jails are usually smaller than prisons, and jails are for short-term stay. I was able to extrapolate 50 EMRs that were reviewed for this project, and the data abstracted from the EMRs were from obviously an adult male inmate population only, but about 50% Caucasian, about 50% from other ethnic groups. And again, age range there, only male genders, and again, the data was abstracted from the EMRs, from inmates with a documented diagnosis of hypertension who needed this care. So as a sample would go, how do we look at the data that we have? How are we approaching to use the information we have now at hand to evaluate the success or the potential success? So the project, again, we were using quantitative, specifically numerical data, so numbers. The use of this data was used to evaluate if hypertension management made a statistical difference, right? We want to know if our data makes a difference. Specifically, we focus on systolic blood pressure with pre-post review over 8 to 12 weeks. Again, I gave myself a little more leeway because I didn't know if there would be specific holdups in certain areas. So to manage the data, the author collected the de-identified data, transcribed it onto a data collection sheet, and then we imported it to an Excel document. Then the numerical data was uploaded to the statistical package for social sciences, SPSS. Numerical statistics utilized guided the statistical analysis. Systolic blood pressure initiation results were analyzed using a paired t-test. Very important. We'll be talking about that in a few moments here, a little bit more in depth. Dependent variables were the systolic blood pressure. We wanted to know if that top number had much of a difference. Although the lower diastolic blood pressure was important, we wanted to see if we made a difference on the systolic blood pressure. So independent variables being the pre and post testing, and the goal is to achieve a power of 0.8 in scale value. Paired t-test is used in many ways to compare whether the mean difference between pairs of measurements is 0 or not over a period of time. So the sample size here was 50 jail inmates between the ages, again, 18 to 89, with a diagnosis of hypertension. So now we've kind of set up our group, we're plugging them into this paired t-test, and we're going to see if this makes a difference. Now, granted, during this project, I did consult with the Maryville statistician, Dr. Pals. He was very pivotal in helping me look at and supporting this mathematical inference to the data that we had to ensure if we had proof or not that this would work. Data analysis. So let's take a look and review how was this processed. The data collected to review if changes occurred for hypertension were analyzed again with a paired t-test. Again, appreciation to Dr. Pals. Certain assumptions must be made with a paired t-test. So why would we do this? So specifically an assumption is made that there's a dependent variable in this research, and that is the systolic blood pressure must be normally distributed for both of the pre and post testing parameters. So we now know what has to be available for the values to make sense. Different settings can create different scenarios which would require different testing. That all has to be perfectly in line for any of this to make sense. We want the value of the number to come out to give us a value that makes sense for the project we're trying to achieve. We're trying to see, is systolic blood pressure better after what we did? Yes or no? That's what we're looking at, because if it does, then we know we've made significant. If not, then it didn't work. So the paired t-test, it was robust. It had a really great assumption of normality versus other tests. We looked at that. We reviewed all of that data. We actually plugged them in, we checked them, and it just didn't make as much sense as a paired t-test. Many studies have been used, again, with the aforementioned testing in order to compare pre and post systolic blood pressure as a standardized methodology. So in order to know if there's a statistical difference, again, we want that p-value, though, in this case, to be less than or equal to 0.05. So results. So statistical and descriptive analysis showed a statistical difference, significant difference, with new updated guidelines, which was amazing. That's what we wanted, and on average, the male jail inmate systolic rates were improved. This was amazing. I wasn't sure necessarily going into this if it was going to make a huge difference, but I think the way that we also approached it helped significantly with the goals we wanted. We kept it very simple, and that lent itself to, I believe, the success. A paired samples t-test indicated that there was a difference. We had a significant difference, which was really exciting because we're improving patients' lives. We're making people healthier, and we're preventing cardiac adverse events. And here are the results. So this was one of the more exciting moments for myself when I was able to put this together, which took a while to find something that was engaging but also visually appealing to represent a difference. Some of the information I had was quite detailed and busy appearing, so making the graph with this very easy approach was really fun. So you can see the before, you can see the after. So you've got rates almost up to 200 with some of these inmates, and huge differences. Now, I will say there was a combination of reasons why this occurred. We did have participants per the jail medical staff that were very eager to approach the improvement to their health. It also meant better food. I think that was another motivational factor. You didn't have these prepackaged aspects. Things had to be made with lower salt, and quite honestly, I think it tasted better for the inmates. But again, some had to be, there were a certain amount that had to be on medication. Some came in knowing that they had to be on meds, but hadn't explored other options. So this was really exciting to see this graph. I mean, once I saw this, it was clear, it's obvious. Here's a difference. We've put it into action. Limitations. So there were some aspects that were also very interesting as we were screening to find out if participants were properly going to fit into this model, especially for this retrospective study. So there wasn't significant barriers or limitations during the process. Of course, there are always small barriers, which can create large barriers. Communication with the medical staff often would take several days to reply to emails or calls, but this made sense. They're taking care of an entire jail full of inmates with multiple health issues, and at any point they might have to focus on an emergency. So that is why I gave myself 8 to 12 weeks to really approach this, and I started really early. So that actually accounted for many of the delays and made up for any aspects that were delayed. So that was really helpful. Another barrier, though, was driving to the study site. Typically, jails and federal prisons, in this case for jails, are not really within the main population. They're outside of town. They're in rural parts, and it was about an hour each way, and that's without traffic. So it did take quite a while to get there. With traffic, it could be an hour and a half. So this did cause a delay to finishing certain parts of the projects or aspects, often until very late into the night, especially with working full time and family responsibilities. There was a lot of midnight candles being burned, to say the least, to get this to be properly completed. But it was great because jails are open 24/7. So there was a benefit to that, I think, in this case, which is unique. There wasn't limited to normal office hours. Other barriers, though, were formulating statistics. It was difficult looking at what statistical analysis needed to be done, and also something that wasn't not pleasing. We wanted something that was pleasing to look at, made sense, was simple, and so again, having all the support of the Maryville staff made that happen. Discussion. So this study's findings established the importance of providing hypertension interventions to male jail inmates receiving care and documenting the outcome of such interventions. So the data analysis results elicited for the pre-intervention and post-intervention after hypertension protocols completed on admission and throughout the above dates supported the aims of this project. Findings showed a significance was found for male inmates between the ages of 18 through 89 and improved control for systolic blood pressure. So overall, the findings meant we found improved systolic blood pressure after we set up our new guideline. We established our project, which was great. I was very excited to see that. Because going into this, you may not know if you may get anything. And there is value, though, to find if you don't get the result you want. It does tell you something. It helps you change the navigation that you would maybe approach to it again with a different goal. And that's the whole point of science, is we're exploring through these formative ideas and structures to accomplish a change that's great on a large scale. So how does this change implications for practice? When new data reveals improved blood pressure based on current research, it's going to shift how clinicians follow and to achieve that for patients. So for example, and kind of as I was prefacing earlier, there are different goal parameters for someone who's 40 years old versus someone who's 80 years old and diabetic. We're going to have different goals. Also, the guidelines, I will say, in terms of future practice, it doesn't review clinician preference. Each patient truly is unique. So these are really just that. They're a guideline, they're a foundation to make these decisions to kind of back up what your goal is using the best evidence we have. So it's not to forget that there isn't the art of medicine. You want to tailor treatment plans for those who are willing. Patients sometimes aren't willing. You have different socioeconomic backgrounds. You have different cultural preferences. Those are not often considered for the guidelines, and so The research pool can be also non-gender affluent with the transgenderism movement. So how would we improve this? Well, so research continues to improve medicine updates. That's how it works. It builds on each other, constantly adjusts and improves itself every time there's a new guideline released with new scientific findings to back that up. More research is needed in this specific area and should just be considered as an aspect of care. So, cornerstone of medicine is to constantly change for the betterment of patients. Taking into consideration the cultural aspects is really my main point here. I think but also applying this new data needs to be applied consistently. And when we're focusing on separate guidelines, I do think that certain specialists should have different guidelines. This should include pregnant patients. This also include vulnerable patient populations, such as those in jails. You just can't approach it as a one-size-fits-all. So should there be different aspects, different parts of it, jetted off in different population, rural versus non-rural, gender, age? I think that new research especially would be very valuable for general practitioners. Um, there's going to be unique situations in every moment that you're going to be, especially with specialty demographic. I would also like to say that the transgender population has higher rates of substance abuse, which can create specific screening needs outside the general population when approaching blood pressure. But the same thing is true with jail settings. You've got higher rates of drug abuse. So that all needs to be just thought of. And so future research and policy creation should examine and review to include blood pressure categories within rural versus urban settings too. So this might provide additional awareness and specific indicators to include that clinicians might forget to ask. So implications for the policy creator of clinics can use all guidelines as a stepping stone to tailor to their own clinical individual needs. Again, it's just a foundational starting point. It is a well-suited catalyst to ensure quality and safety for those who are interested because it's reviewed, it's studied and documented and proven to be repetitively successful. And that's the whole point of a study. Can it be repeated safely and accurately with the same results? And a final recommendation is that all clinics should review their processes and policies just to ensure that they're not outdated material. Make sure that we update it for patient safety and current literature. We get busy. Sometimes it's important to look at what we do every day and change what we do and not do it just because we're used to doing it. Conclusions. In this scholarly project, again, the author, myself, we found a difference in adult male jail inmates between ages of 18 through 89. There was a total of 50, and we improved their blood pressure with a new guideline that was proven with data. The next steps, though, for the jail medical staff to adhere to these new practice guidelines is really that long-term aspect, especially with the aspects where you're freezing and unfreezing and putting these new habits into form. So as long as the jail setting continues with this, I think they'll be successful. The jail really is a unique and a higher than normal vulnerable populations than average clinics. These settings, you want to make them successful, especially with these hypertension managements. They'll take these aspects that they learn within the jail, within these healthcare literacy and long-term goals, and they'll put them into the community, and they can even improve community health. In practice with national guidelines will certainly improve the confidence of the medical provider in these areas, and it's just a place to begin for many places, but it can have long-lasting effects, which is the goal. That's the hope. We want to prevent things before they get worse. And it's important to remember these guidelines, again, they're not a replacement for unique individual circumstances. The use of implementing evidence-based medicine is crucial and done now nationally throughout the U.S. That's what the expectation is. I like to remind the audience, keep an open mind to industry shifts and understanding the dynamic emotional burden change can have on medical workers when you put these new aspects into place. So time ultimately is what is needed to make new habits, and it can feel uncomfortable, but reinforcing the education and science of it ultimately will lead to success. We must be patient with ourselves, never cease to focus on constant improvement for our community health. And a last reminder to all medical workers in medicine, new or experienced, the only constant continuum in medicine is change. Definitely. And I will say, in terms of closing thoughts, this project has meant a lot to me. It's been a long time coming, many barriers, many challenges, and thanks to the Maryville support staff, all the educators, teachers, counselors, everybody, the individuals and workers at the jail cell, it just wouldn't have been successful without those individuals. So I really, truly appreciate it. This project means a lot to me. I'm the first person in my family to have a doctorate, and I can't believe that it's already almost coming to an end here. So I really appreciate what everyone has done, and this has meant the world to me. So it's been very, very important for me and very satisfying. And at this point, I will be able to take any questions that anybody has. And of course, that will be later approached. And here are references. Thank you very much for listening to my project, and I appreciate everybody's time.